Hello everyone, I'm Dr. Rashmi Vaidya, breast surgeon with Ironwood Cancer Research Centers, and I work out of the Glendale office and the Phoenix office. I'm here today to talk about who needs a mastectomy. People wanting mastectomies for various reasons has increased significantly over the last decade, and I want to discuss today the reasons why people might choose it, who really needs it, who benefits from it, and some of the people that really don't need it at all. I'm joined today by Sarah, our medical student. Thank you for joining us.
Thank you for having me.
So Sarah, in the last decade, it was in 2013, I think, when Angelina Jolie went public with her decision to undergo bilateral mastectomies, that is removal of both the breasts, for a bad mutation, which what she had was BRCA1 mutation that increases your lifetime risk for breast cancer up to an 85%. And she also had a family history of breast and ovarian cancer, and so she chose to do what is called as risk-reducing mastectomies with reconstruction at the same time. Since her public sort of announcement about this, a lot of women have gone for this procedure, and more women are choosing to do this procedure. And the unfortunate thing is that not all of them are going to benefit in the way that she did. So today let's talk about who benefits from doing this and who does not.
So Dr. Vaidya, who does benefit from having mastectomy?
So there are some patients that have really bad mutations, like we talked about BRCA1, BRCA2, P10 is another mutation which is a high-risk mutation, also a P53. So there are some mutations which increase your lifetime risk for breast cancer anywhere from a 30-40% all the way to an 85%. So in these patients, especially if they also have the manifested in their family history, many women or men with early onset breast cancer, early ages in life, and multiple family members, then those women truly are carrying that risk of getting a breast cancer, and not just one but multiple breast cancers in their lifetime. And they would truly benefit from having this discussion with their surgeons about undergoing risk-reducing mastectomies with reconstruction or without reconstruction if they choose that. So they do benefit. Other groups are women who have multiple family members at very young ages getting breast cancer, like younger than 40 and younger than 50 or 55 if they have cancers in both breasts. So if they have multiple such family members and yet their genetic testing is negative, then perhaps we don't know yet about what gene might be running in their family which is mutated, because of which they are getting these cancers. So those people might benefit from the discussion and from undergoing that risk-reducing surgery. Besides that, there are some women who have had to have radiation to their chest wall when they were younger than 30 years of age. And that is a lot of radiation which was done to treat some cancers like lymphoma sometimes. And when that happens, they do have an increased risk of getting breast cancers about 8 or 10 years from their treatment for the lymphoma.
Right.
This exact risk is not been quantified. However, if these women present with breast cancer, then it is quite reasonable for them to be considering getting rid of both the breasts for their risk reduction for the future.
So if you do have this genetic testing or one of these risk factors, is it a viable option to just remove the breasts just to be safe?
Right. So in these cases, in these specific patients with these kind of mutations and this previous radiation history, these patients do benefit from the mastectomy. The risk reduction can be a 90-95%. And when these patients with BRCA mutations are studied in the future, the actual incidence of cancer in the chest wall is less than 1%. So this group of patients does truly benefit from the risk reducing surgeries. However, what has happened is what is now very popularly called as the Angelina Jolie effect, where even women without these mutations are choosing to undergo this very extensive procedure in the hope that they will get the same benefit.
Right.
Now, the unfortunate thing is that that is not the case, because their initial risk for getting a breast cancer itself is very low. And when they do these extensive procedures, they are putting themselves at increased risk for complications and increased risk of multiple surgeries, increased risks of not having a good cosmetic outcome, none of which they sort of think through before they make that decision. So that's the unfortunate part.
Right.
Now, when patients are presenting with very small breast cancers, very early breast cancers, only in one breast, they oftentimes make a very emotional decision about getting rid of both the breasts and wanting to do a reconstruction at the same time. Many times they are ultimately not happy with the outcome. They need several repeat surgeries because of complications of the surgery or because of needing revision procedures for the reconstruction. And what ends up happening is that because the complication risk is doubled when we do double the surgery, there is a very real potential that treatments that they might need after their surgery for the cancer actually get delayed, such as chemotherapy may get delayed, radiation may get delayed because of the surgical complications and the repeat procedures that they have needed. And this delay could be, if they are lucky, a few weeks, or it could be a few months, depending on what kind of surgical complications occurred. And this delay, if it is a significant delay in other treatments, which we call as adjuvant treatments, that has the potential to impact their outcomes. So that is a real risk. Besides that, there is change in the way they sense the breast tissue. So there is no sensation in the remaining chest wall when they do mastectomies. Even when they do nipple sparing mastectomies, there is no sensation left in the nipple afterwards. There is no erectile function, there's no arousal, things like that, which would matter to a woman's sexuality, even beyond the surgery and beyond the treatment for cancer. So many times it's a question of how much do you want to do and how much should you do all together. And perhaps if we can put a distance between what the patient needs to do for surgery for the cancer treatment and what she wants to do for, say, a symmetry between the two breasts, or to do reconstruction so that both the breasts look similar, maybe we can put a deference on that decision, and maybe it can be a stepwise decision about what to do for the other side, whose risk for cancer is nowhere close to the risk of them getting a repeat cancer in the same side even after a mastectomy, or a cancer somewhere else in the body.
How do you get cancer in the same side as a mastectomy?
So the reasons we would get the recurrence on the chest wall is because microscopic amounts of breast tissue can remain behind under the skin, under the fold of the breast, and going towards the armpit. So from these areas, the recurrence rate is about 4 to 5%. And that remains the same even after a mastectomy.
Wow.
So that doesn't change. And also, doing a mastectomy does not mean you will not need chemotherapy or you will not need radiation if it was determined that you are going to need these treatments anyway, even before you decided on the kind of surgery. So the hope of avoiding other treatments is most of the times a false hope. The other equation that women need to understand is doing a risk-reducing mastectomy on the side opposite to the cancer side does not improve their survival. So they do not live longer after the treatment of the cancer just because they also took the other breast off. It also does not change their outcomes from the existing cancer. So the recurrence rates in the whole body or in the chest wall, they remain the same. So truly, the benefit of removing the other side breast is in reducing the risk of a new cancer developing in that breast and not needing mammograms. That risk of a new cancer developing in the breast after the other breast has a cancer treated is about 0.5% per year.
Wow.
Or less. Now, the treatments that the patient has, like chemotherapy or taking hormone pills that are actually anti-hormone therapy, which are medications that block the hormones in the body like estrogen and progesterone, those medications and the chemotherapy have been found to reduce the risk of getting a new cancer even further. So the risk for an average person with a small early breast cancer with no family history could be as low as 0.2%. So that doesn't truly justify going through such an extensive procedure and not truly getting much benefit from it.
Right. Yeah, so there seem like there's a lot of different factors and things to consider. It's a lot of things to balance out, especially when you're concerned with that kind of risk in yourself. What's the best way to go about deciding what's the best treatment for you?
That's a great question, Sarah. So I think this needs to be like a multidisciplinary team decision involving the patient.
Right.
And we have to consider their individual risk, based on their family history, based on how many times maybe they've had callbacks for multiple high risk features in their breast, maybe how many biopsies they end up getting per year because their mammograms are so hard to read, or if they've had some high risk treatments in the past. And also the other factors to consider are how is their personal health. If they are older, if they have a lot of problems like heart disease, if they have diabetes, if they have been on steroids, if they've been smoking for a long time, if there is obesity. So all of these factors would be high risk for them to be getting all sorts of complications during surgery, after surgery, and making their recovery much harder than other people who don't have this problem. And these patients truly would not be good candidates for considering this sort of a risk-reducing procedure. Also, patients who have advanced cancer, patients who have inflammatory breast cancer and are undergoing treatment, these patients should really be focused on treating the cancer first and doing all the different treatments that are recommended in sequence rather than trying to get rid of a perfectly normal breast on the other side in the hope that it will prevent having a recurrence ever in the future, which is a falsehood.
Right.
Well, this was a good discussion.
Yeah, thank you so much. It's been very informative.
Here. Yes. Thank you all for joining us. If you enjoyed this content, please visit the Ironwood YouTube page for more such educational videos. Thank you.